We really want to welcome you. We're going to get started right away. I am Jenny Loudon, and I'm one of the co-founders, and I'm also the current board chair of the Alaska Eating Disorders Alliance. And today's Echo really is an opportunity for interdisciplinary healthcare professionals to connect with eating disordered experts and with each other. So today's program will include a didactic presentation. We'll have some time for questions and answers after that, so please be keeping track of questions you might have, as well as a case presentation. Our series has been guided by a hub team of professionals in the field, and they will be introducing themselves in the chat. Feel free to reach out to them with any questions. I do want to just give a big shout out to ConocoPhillips Alaska. We could not do this Echo without their generous financial support. It is really as a result of them that we're able to offer this world-class educational event at no charge to participants. I do want you all to know that you may claim 1 credit hour of continuing education if you are attending for at least 90% of today's live session. And there will be a link provided at the end of the session that will allow you to complete the evaluation and download your certificate. A few Zoom reminders. There are closed captions that are automatically being generated. If you need those, please access them by pressing the CC button at the bottom of your screen. If you are able, please keep your camera on and your mic muted unless you are asking a question. And we do encourage those questions. Use the chat box at any time and we'll answer as many as are possible. Finally, I do want you to know that the opinions of the hub team and the presenters are their own. They don't necessarily represent those of AKEDA or any ECHO sponsors. Additionally, our Project ECHO is not HIPAA compliant. Therefore, no protected health information will be shared or displayed at any time. And we really thank you all for following those guidelines. So as we get started, we do acknowledge that we are hosting this session from Anchorage on the unceded lands of the Dena'ina people who have lived on these unceded lands for thousands of years. And we thank them for their stewardship of the lands, the water, the air, and of all life that sustains us. And we respect the Dena'ina cultural ways and homelands and will strive to be good neighbors. So now on to our program. Our didactic presenter today is Sydney Greene, who is a registered dietitian, who is sometimes referred to as the sober dietitian. She has worked in behavioral nutrition space in private practice and as a freelance writer, as a speaker, and a consultant to addiction treatment facilities. Her focus areas really are on nutrition for addiction recovery, disordered eating and body image, as well as chronic digestive issues. She holds both Bachelor and Master's of Science degrees in nutrition from New York University, and she's also a skilled soulful eating and nutrition group educator. She belongs to the International Federation of Eating Disorder Dietitians and also serves as the addictions resource professional for the Behavioral Health Nutrition Practice Group of the Academy of Nutrition and Dietetics, as well as being involved with the Addiction Special Interest Group on the Academy of Eating Disorders. So I can, from all of that introduction, you can tell that she is a real knowledgeable expert in this area, and we're thrilled to have you. So we'll turn it over to you now, Sydney. Thank you.
Awesome. Thank you, Jenny. I'm going to go ahead and share my screen with you all. Can I get a thumbs up that you can see my slide? Awesome. Thanks. It's so nice to be here. Thank you so much for having me. I'm thrilled to be talking with all 66 of you right now. That's awesome. We don't have a ton of time for the presentation, so I won't, spend a lot of time droning on who I am. You got a snapshot of it. But as was said, I'm a registered dietitian. I'm speaking to you from Boulder, Colorado, but I see clients all over the country. And I want to name just at the top of this presentation that, yes, from my bio, as you can see, I have experience clinically working with eating disorders as well as substance use disorders. And also I have lived experience. I myself am in recovery from both a substance use disorder, an eating disorder, trauma. And so this population is near and dear to my heart. And I'm just thrilled to be giving you a snippet of this very special patient population. Just one or two maybe housekeeping notes. Because we only have like 25 minutes to get into the nitty-gritty of it all, if you have questions, feel free to put them in the chat and I will address them at the end, unless it's like a burning question that you need me to answer in real time. Maybe Kaylin can give me a shout, but just for the purposes of continuity, I'll try and get to those at the end. So, we're going to be talking about navigating dual challenges, substance use and disordered eating. And it's important to say it just at the top that this population is understudied. And the reason why it's understudied is because if we think about putting together a research study, right? And let's say we're going to do that study on alcohol use disorder. Most researchers want to control their group as much as possible. And so they'll often weed out individuals that have eating disorders or have another psychiatric disorder, um, unless they're specifically looking at substance use and eating disorders, but that's not super common. And same thing on the flip side. So if we're looking at a study of bulimia nervosa, right, they're often going to screen out folks who have an active diagnosis of, let's say, opioid use disorder. So this is a population where there isn't a ton of evidence-based treatment on how to treat co-occurring substance use and eating disorders or disordered eating. Um, and this is a population where the risk can be quite high. We know that individuals who have a substance use disorder alone are at a higher rate of mortality compared to folks without a substance use diagnosis. And the same thing goes for an eating disorder, right? We know that eating disorders I believe, the most lethal mental health disorder. And so you put the two together, and the risk is certainly very high. And in fact, for individuals struggling with anorexia nervosa, when they're also diagnosed with a substance use disorder, the risk of mortality increases by about 20-fold. So, this is a group that urgently needs our care and attention, but oftentimes they're a group of people that are thought of as the challenging clients, the provocative clients, the clients who are treatment resistant, who might fight against their treatment team. And just to give you some kind of snippets, I was telling a friend who's a therapist about a week ago that I was preparing to give this talk with all of you. And she specializes in addiction. And she had just told me that she got a referral for someone who's in recovery from alcohol use disorder. And the clinical director of the treatment team called my friend and was making a referral and said, "Oh, by the way, this person also has anorexia. But don't worry about it so much. Like, let's just focus on the anxiety that she has." And it became this interesting back and forth, she said, where it was very clear that there was a lot of nervous energy around someone having an alcohol use disorder diagnosis and anorexia and anxiety. And it creates a ton of panic in treatment settings. When I worked in a residential addiction treatment center, we had this woman who was in her early 30s. I believe she was admitted for cocaine use and maybe alcohol use. And it said in her chart that she had a history of bulimia. And she came into treatment, and 2 weeks into treatment, she doesn't have her substances anymore. And so she started purging. The entire facility started to panic. In our clinical meeting, it was, oh my God, what are we going to do with her? She's purging. We can't keep her here. Oh, but she's only 2 weeks into her treatment. Is she going to relapse if we send her somewhere else? Oh, we need to send her to an eating disorder facility. We can't handle, right? We can't handle her. And if we just slow down and think about it for a second, this is an individual who, and I'll talk about this in a few moments, right? People don't just start using disordered eating behavior and substances in a vacuum, right? Usually there's some sort of underlying thing at play. And of course, if we take away someone's coping skills of cocaine and alcohol, and they're in a facility where they can't turn to that, And maybe they haven't developed a ton of skills yet to regulate their emotions and their nervous system and their feelings. And they have a history of eating disorder behaviors. Well, of course, they're going to turn back to those old behaviors because at one point in time, they serve some purpose, right? It's a way to soothe, to regulate. And so it's just what was available to her in the moment. So the treatment center went into panic, right? Of course, there's other things at play, someone's safety, the milieu. Um, but these are people who are really struggling and need to be heard, seen, and believed. And that client ended up needing a different type of treatment for a myriad of other reasons, right? But what my hope would be that from this snippet of a presentation, you feel more inclined that instead of when an individual appears with a dual diagnosis, and if you're not familiar with that term, dual diagnosis means someone has a substance use disorder and another comorbidity, whether that's an eating disorder, depression, anxiety, bipolar. So if somebody appears with a dual diagnosis, we can slow down for a minute instead of panicking. These are people that really need our support and not to, they feel it too. Clients are aware of kind of what's happening and the energy that's in the room. And having both an eating disorder in and of itself can be their stigma around it, and substance use is definitely their stigma around it. And so having the two, these clients need care and openness. So just some stats. Up to 50% of individuals with eating disorders have used alcohol or illicit drugs, which is a rate that is about 5 times higher than the general population. And then thinking on the flip side, up to 35% of individuals who are dependent on alcohol or other drugs have had eating disorders. And that's a rate that's 11 times greater than the general population. And it can be really interesting to do some of your own research and see how substance use varies across different eating disorder subtypes. I'm going to read some statistics to you. I think it's interesting, and we don't want to only rely on the statistics because we want to be open to what the client, what their experience is. But so here are some stats. About a quarter of individuals who seek treatment for bulimia nervosa also suffer from an alcohol use disorder. There is a lot of information out there, probably, I don't want to say the most, but more research on alcohol use disorder and bulimia nervosa. To be honest, I'm not sure why those two have more research behind them, but they do. Um, Purging behaviors are associated with amphetamine use and sleeping pill abuse. Up to around 12 to 18% of adults with anorexia nervosa and around 30 to 70% of adults diagnosed with bulimia nervosa have a substance use disorder. This one, not super surprising, right? But individuals who have binge eating disorder have also shown issues with cannabis use as well as alcohol use. That's something that I see clinically often, and frankly, something that kind of goes underneath the surface. I think cannabis today, and this could be another presentation in and of itself, falls in this murky area of plant medicine, and especially as it's more legal in certain states, I think both clients and clinicians who don't necessarily have a background in addiction don't, for some reason, see cannabis use as like a red alert. But oftentimes I'll see clients come to me who are struggling with binge eating, and maybe not in the first session, maybe not in the second session, but usually down the road it comes out that they're using cannabis every night or every day. And maybe it's not to a point of excess, but it's definitely driving the binges. And the same can happen with alcohol use as well. Um, Interestingly enough, men with binge eating disorder tend to have higher rates of substance use disorder compared to women. I say interestingly enough, because at least clinically in outpatient, I tend to have more female identifying folks seek care than male identifying folks. And several studies in adolescents have found that about two-thirds of those individuals with bulimia nervosa have used alcohol, one-third have used cigarettes at least once, and another third have used illegal drugs at least once. And among those adolescents who have used illicit drugs, marijuana was the most used, followed by cocaine and then amphetamines. And so those are some statistics, and you could find plenty more. But I think what's more important than knowing the different subtypes and what substances they're associated with is knowing your client and not being afraid to ask questions. What I mean by that is if I have a client coming to me who's struggling with bulimia, it's not really top of my mind that, oh, maybe she's going to be struggling with alcohol use as well. I want to remain open to whatever that client is experiencing. I think where the statistics help me in clinical practice is oftentimes clients can get really hard on themselves. I know I was really hard on myself of like, why am I struggling with both of these? Why both? Why not just one? Not everyone struggles with both of these things at the same time. And sometimes having those statistics to fall back on to share with a client can be validating in a way. You know, you're not alone. There is a link. Here's how the two are linked, and I'll talk about that in a moment. So just being open and really asking open-ended questions to the client, letting them share with us what it is that they're experiencing. So I get asked this a ton. Do we treat the eating disorder first, or do we treat the substance use disorder first? Remember, this is a population that doesn't have a ton of research behind it. And so there is no gold standard protocol. In general, what I tend to follow is that medical stabilization should come first if needed. And we follow first with that and then go from there. So here's an example. 2 weeks ago, client reached out to work with me on her disordered eating. She found me because I spoke on a podcast about eating disorders and substance use, and she had shared that she was abusing several different medications and she would like to get sober and also work on her restriction. I'm an outpatient dietitian. Somebody wanting to come off of their medication that they're abusing needs medical attention. Additionally, if somebody's actively using, getting high, it makes it really hard to key into things like appetite, fullness, to follow a certain meal plan. And so in terms thinking about the sustainability of our work together, it wouldn't make much sense for her from a budget standpoint or time standpoint to start doing that work if she was actively using. So in that scenario, she was open to receiving higher level of care, and I connected her with a facility that treats both eating disorders and substance use disorders. So she could go through any detox if needed and then receive care. And maybe I'll see her when she discharges, maybe I won't. But that's how I tend to think about it, right? Is okay, first of all, medically, are they safe? What should come first? I can tell you of another client who came to me for binge eating. It then became clear she was also using weed every single night. It made sense to kind of work on both at the same time, and her therapist was on board and her psychiatrist was on board, so she had wraparound support. It wasn't this scenario of first let's work on the binge eating, then let's work on the cannabis use, or vice versa. The two really fed each other, so it made sense to work on the both of them at the same time. So it really depends on the person, but I think, of course, safety always should be top of line in terms of what do we treat. And also to that point, too, I just want to say when clients are open about their eating disorder and substances, it can be interesting to explore how the two feed on one another. For example, with alcohol and restriction, again, I don't see that a ton, but it happens. Often people will minimize the amount that they're eating because of the calories in alcohol, or they're minimizing the amount that they're eating because they want to get drunk faster. And just exploring their beliefs around their food behaviors and the substances and how they connect and how they feed into one another can be really helpful. So I tend to think of eating disorders and substance use disorders and other behavioral process addictions, um, tools that are in kind of a crusty toolbox. It's like not the best toolbox, but it's just what you have. And they all kind of share similar characteristics and traits. And so this is the disease model of addiction. So just high level, again, you could research this and do some more reading on it. But someone gets intoxicated, they use a substance and experience rewarding and pleasurable effects. Afterwards, there's withdrawal, usually followed by negative emotional state in the absence of the substance, and then there's preoccupation and anticipation, where an individual is seeking out that substance again after a period of abstinence, and thus the cycle continues. And I think that that maps pretty well onto one way of thinking about dysfunctional eating, let's call it. Um, so someone might want to restrict their food, they attempt to control. So let's just use an example. Someone says, "Oh, I've eaten so much sugar. I'm not going to eat sugar for the rest of the month." They then fight food urges. I call it white knuckling. That's often used in the substance use world, where an individual is like grip it, just like white knuckling it, trying not to use their substance, and they become more susceptible to stress or triggers. So if you're actively just restricting sugar, and maybe that's something, a way that you cope, we take that away from you. Now you're more vulnerable to stress and triggers. Then let's say you get an email and that's it. It's the tipping point. You either binge or overeat, or maybe there's a binge followed by a purge. There's then feelings of guilt and shame. We're feeling remorseful. We make promises. I'm not going to do that again. I'm not going to eat sugar again. And thus the cycle continues. And so I think the two can kind of map um, similarly onto one another. And I just want to read, checking my time. Cool, we have time for this. I just want to read a little snippet from one research study that I believe is in my reference list. It says individuals with anorexia nervosa behave similarly to individuals with substance use by narrowing their behavioral repertoire so that weight loss, restricting food intake, and excessive exercise interfere with other activities. So if we just pause there, we know that when someone's in their active ED or engaging in substance use, their world often gets small. We're saying no to social engagements. We're doing things that really interfere with our quality of life. So it says this is reminiscent of individuals with addiction who forego many activities and responsibilities for the sake of seeking out and consuming drugs of abuse. Moreover, individuals with anorexia often engage in dietary restriction as a mechanism for modulating anxiety and dysphoric mood, much in the same way individuals with substance use modulate mood with drug use. When food intake in anorexia does occur, anxiety increases in a manner similarly to anxiety often reported with periods of drug abstinence or withdrawal. So the two, as I've said now 3 times, map pretty well onto each other. Of course, there's going to be differences based on disordered eating behaviors and the substances that are used, but the models can be similar. And why do these seem to be such highly correlated illnesses? there's a myriad of factors. One, we know that individuals who have eating disorders and substance use disorders tend to score higher on the ACEs questionnaire, so adverse childhood events. Often childhood trauma is present. Both of these conditions have a genetic component. So whether there's substance use in the family or eating disorder in the family, often you hear what I hear from people in the recovery worlds that I frequent is like, you could shake my family tree and alcoholics will fall out of it, right? Same can be said of eating disorders. Parental factors. So we might see someone has a parent who comments on their own weight a ton, and that transfers onto the child. The child might start manipulating their food or different behaviors in a way to modulate their weight. And then when they get to a certain age, they find substances, and that kind of takes the role of how they modulate weight or body or anxiety. So the two can kind of wax and wane with each other. Also, ADHD is commonly found in both populations, and then as well as personality types. So we know that being over controlled or under controlled, having high impulsivity or a ton of rigidity can also play a factor in both eating disorders and substance use. I'll just share in my experience. I am over controlled and pretty rigid in type A, and that worked well for eating disorder behaviors. And then substances came in as a way for me to kind of breathe and relax from all of that rigidity. So it depends on the person, but they can often feed off of one another. So just as we come to a close, what's the path forward for clinicians? I just made it seem like this is a very intense situation for people. And again, no real gold standard, right? But what the research does show is that interviewing is really the most effective way to assess for eating disorders and substance use and to treat clients. So having conversations with clients, open-ended questions, the way that I approach questions with every new client I have is I try to model my opening question with what you might see in a 12-step meeting where someone shares what it was like, what happened, and what it's like now. I often say, so if you're open to it, will you share with me your relationship to food and body and substances, and walk me through to you what happened to you now sitting in my office, right? And so they can share as much as they want. They can take me back to being 5 years old, or they can start with their therapist or someone saying they should go see me, but really trying to make it as open-ended and inviting as possible. And then, of course, screening is just so important. So whether you're somebody that's able to have long sessions with a client, or you're just a school nurse or someone who has very little time with an individual, there are various screeners that you can use. And so you just get a sense of maybe what's going on and then can refer clients as needed. I hit it, 25 minutes. I just want to say thank you for having me. There's my dog. Thank you. She says thank you too. Thank you for having me and for all the work you do. And I'm excited to hear any questions and get into our case for today.
Awesome. Thank you so much, Sydney. It's really wonderful having you here talk. And I really appreciate sharing both from a clinical perspective as well as the lived experience, because I think that lived experience really does have a very important, it adds a different perspective and highlight to it to us as we grow. So we do have some questions in the chat, and I'll start with some of those. And then as if anyone wants to raise their hand, use the raise hand function, feel free to do that, and we can have you join us in a moment with some of those questions. But the first is, so are there differences between how we might think about treatment of of folks with co-occurring if you're an adult versus if you're a teen. This is somebody who works in a co-occurring residential treatment facility for teens. She says we don't turn eating disorder clients away unless they're unable to maintain safety, but just wondering about do we need to be thinking about different approaches or ways of conceptualizing this if you're working with teens versus adults?
Such a good question. So I would imagine in teens, parents play a huge role if that's available. And so when it comes to teens with eating disorders, yeah, I think there is another whole element and component at play that might be a little bit different from substance use disorders. If you just think about it, and I say this to clients, you can live without your substance and you don't need to engage with it, but you have to engage with food 3, 4, 5, 6 times a day. And for teens especially, I think that can be difficult for them to navigate on their own. So I'm going to leave it at that and say that we can talk more offline if you have, I feel like this is a larger question.
Great. Another question. So someone mentioned that there are nutritional deficiencies sometimes associated with substance use disorders, thinking about vitamin deficiencies in particular with alcohol use, and the impact of behaviors and potential increased risk with co-occurring eating disorders. So someone else said, yes, I was thinking the same thing. Are there recommended recommendations for changes in vitamins, mineral supplements, food when you're working with somebody who is experiencing co-occurring?
That's such a good question. I'm doing an exact talk on this at a conference in a few days. So this person can email me and we can chat about it more, but right off the top of my head, I would say a multivitamin is really important for both individuals. There are other nutrients that have some evidence-based interventions for them, like an omega-3 fatty acid can be really helpful for folks, a B complex. But in addition to the supplements, we really want to focus on helping somebody have consistent meals that are balanced and have all food groups. So, yes, for substance use disorders, for folks recovering, the big thing is making sure there's protein at every meal, having some form of complex carbohydrates, some healthy fats, and really encouraging consistent intake of food because that's often not what's happening in active use. Yeah.
Excellent. Um, One person, a couple people asked, so what do we do when there is somebody identified with these high risk substance use disorders and eating disorders, and they need a higher level of care? And wanted to know, do you know of places that are particularly well suited for these kinds of dual diagnoses? Are there places that are taking them? I know sometimes, like you said, even with the research, it's like, oh, if you have both of these things, we don't want to include you in our research. So are there, and I know that that can sometimes happen with treatment facilities. So just
Totally.
a kind of a generalized question about whether that's a problem and if there's recommendations.
So one treatment center off the top of my head, I have no affiliation with them. But they are a 21-bed facility. They have IOP, PHP, and then a residential unit. It's called SunCloud Health, based in Chicago. They take insurance and they do co-occurring substance use and eating disorders. That's their bread and butter. They will see people who have just one, but their real specialization is people that are struggling with both at the same time and treating them both.
Great. So that takes up our time for Q&A. We might have some time at the end. So if you do end up having additional questions, feel free to include them in the chat and we will try to come back to them if we have time. And if we don't, what we can do is share those with Sydney after the fact and see if she can provide some written answers. But at this time, I just want to thank you, Sydney, for that excellent presentation and turn things over to Katie Bell.